Dr. Felson is an epidemiologist, studies the risk factors for osteoarthritis and the burden of osteoarthritis in the population. He's the principal investigator of the NIH-funded multi-center study on osteoarthritis, or the MOST study. Dr. Felson is the director of training in ENACT and also directs the training component of the Boston University CTSA. And he's very supportive of all of the rehab sciences. So thank you, David.
So it's a pleasure to be here, Julie, and a pleasure to be involved in ENACT. I look forward to meeting many of you. I've seen many of your CVs, and you're a selected group from among many who applied to come to this workshop, so we're thrilled to have you. I don't have a lot to disclose here. I want to talk about the objectives of what I'm going to do, okay? I'm going to discuss two studies, study design, sampling frame, and methods for two large epidemiologic studies of NEOA, the OAI and MOST, and summarize a little bit of the evidence these studies bring to the understanding of risk factors for the incidence and progression of NEOA pathology, and more importantly, for our purposes among this group, for functional loss and disability from osteoarthritis, and discuss opportunities within MOST and OAI for future research using publicly available data. So I wanted to take a step away for a minute and remind myself that you're all, even though you're fully grown adults as I look out at you, are all young investigators. You're here because you're postdocs or docs or young faculty, okay? And I want to talk a little bit about the advantages of using an established data set with high quality data on large numbers of people versus recruiting your own sample and studying them. I think you have those choices to make. So the good news about using OAI MOST data or other established data sets that are large and well characterized is that you get large numbers of subjects with well-documented, clean data that's fairly easy to use. Okay, the data set contents, especially in OAI, are extremely well explained and relatively easy to use. I don't get questions from OAI, and the coordinating center doesn't get very many questions about what does this variable mean, because they're so well explained. Okay. Large numbers make it easy to get your findings published. When I'm an associate editor of a journal, and when we see a paper, the first thing we do is look at numbers. Okay, how many subjects are there? And OAI and MOST don't have any troubles here because the numbers are very large. The studies were both designed with lots of investigator input so that major measures of interest were usually obtained. Now, the one exception to that is rehabilitation sciences maybe didn't have optimal input to some of these, but there was lots of input here. And you can do meaningful project quickly. You don't have to wait for things that I know you have to wait for when you try to do your own studies, okay, which is IRB approval and then re-IRB approval, okay? Recruitment, which often is frustrating, and then follow-up with patients who were already studied to get some follow-up, okay? So it's better for you as a young investigator who may have limited time to try to write papers and establish yourself to take advantage, okay, of studies like this, including studies that you may have access to at your own institution that have already collected data where you can take advantage of that data collected. And at the same time, if you're developing your own career locally, to then go ahead and pursue some of the questions you have for yourself that do require new data collection with new measures that weren't collected in these data sets. Okay, so that's a nice sort of juxtaposition for you of going ahead and taking advantage of what's offered here and in other large data sets, okay? And then in addition, and getting some papers out of that and being able to address some questions that'll advance your career. And then go ahead and, because you've developed measures and interests of your own, pursue those with some of your own recruitment and data sets. So, as you already know, I think, knee osteoarthritis has a big population impact. Anywhere from 12 to 15%, age 65 and over in the United States and in the UK, have symptomatic knee osteoarthritis. About 25% of adults have chronic knee pain, and chronic knee pain and knee and hip osteoarthritis are the most prevalent disabling condition among older adults, and certainly the number one cause of mobility disability. I should just mention that you might say, well, 25% have knee pain and only 15% have symptomatic OA. What about the other 10%? And the answer is, based on MRI studies, they probably have knee OA too, okay? So that the prevalence of knee OA in people age 60, 65 and over is not really 12%, it's more like 20%, okay? It's very high. And we're not talking about X-ray positive OA or MRI positive OA. We're talking about people who have knee pain on most days of a recent month and whose images, either MRI or X-ray, show evidence of osteoarthritis. So this is, by any more rigorous definition, a highly prevalent disease. Pain and activity limitations are common. 50% are limited at least one daily activity, and about 20% of affected persons are unable to walk even a quarter mile. And it's unusual for patients with symptomatic knee osteoarthritis to meet CDC physical activity guidelines, which probably puts them at risk of diseases far beyond their knee osteoarthritis. So there are many unanswered questions in this chronic disease. This is really one of the last unconquered chronic diseases in our society. We've managed to conquer rheumatoid arthritis. We've managed to conquer asthma, hypertension, a lot of heart disease, and many types of cancer. But there are limited numbers of major chronic diseases that we just haven't figured out how to deal with, okay? And this is one of them. What factors are related to incident disease and disease progression? Those are unanswered. What factors increase people's risk of developing severe pain, functional limitations, physical inactivity, and restriction? Those are really, to a large extent, unanswered. And what are the best rehabilitation strategies? And that's unanswered, and I won't address it with the most in OAI study. So we're going to talk about longitudinal cohort studies, and I'm assuming that you all have basic study design background sufficient that this isn't a surprise to you, that we take a population of interest or a risk group of interest and follow them forward after identifying them and characterizing them. So we could address a lot of questions with longitudinal cohort studies. Is quadriceps strength or knee varus alignment a risk factor for incident disease and or long-term functional performance? What is the natural history of functional decline in this population, and what factors predict functional decline? If we identify modifiable factors that predict functional decline, we could identify intervention strategies. That's the goal of this, is to ultimately figure out what we could do to prevent this stuff. Does the environment in which older adults with arthritis live affect their activity and performance? Should we be focusing our attention to environmental strategies that might be achievable in order to make participation more and disability less? So the good news about cohort studies is there are large numbers of people with lots of statistical power to address questions, enhanced abilities to identify risk factors for incidence and progression, and the potential power to compare subgroups with different ethnicities or backgrounds, with different BMIs. It's good for studying disease etiology and risk factors. Disadvantages are that it's very hard to evaluate interventions, although with bigger numbers and better characterized granular information on populations, so-called big data, even that is becoming possible. It's difficult to rule out confounding by other factors, although we obviously have attempts. We have strategies for those. There's selective loss to follow-up that can lead to biased results. And these are costly studies. These are multi-million-dollar studies, fortunately supported by NIH and other large agencies. So let me talk briefly about most in OAI, and I'm going to also include something about which should you use, okay? If you're interested in a data set and you're thinking of asking questions where the variables more or less have been collected in both of these data sets, which is best for you, okay? Which is the better one for you? So these are two large community-based longitudinal cohort studies designed to investigate the natural history of knee osteoarthritis across the disease spectrum. It includes people at risk who have early or preclinical disease. It includes established patients and those who are end stage. The whole spectrum of disease is there. Evolution of early OA to clinically significant disease, including clinical outcomes, and then the pathology, biology, mechanics, genetics, movement, mobility, disability, all of them are represented, but because the spectrum of representation is so broad, the depth of the representation of each of these is not what you might want for your own focus study. So you might say, wait, they have mechanical data? What do they have that's mechanical? Okay? And the answer is we don't have motion analysis, okay? Because it would take more than half the time we have with the subjects to just get one motion analysis done, okay? So we go broad and not deep more or less. The one exception to that is maybe MRI, but even there we go more or less broad and not deep. So MOST is an observational cohort study of persons with or at risk for NEOA, recruited originally 3,026 subjects at 2 clinical centers, University of Alabama, Birmingham, and University of Iowa. OAI is an observational cohort of persons with or at risk of NEOA that's got an N of about 4,800, and subjects were recruited at 4 clinical centers, Rhode Island, Pittsburgh, Baltimore, and Ohio State. Inclusion criteria are quite similar. I'll show you the difference in a minute. It does speak to some differences between these cohorts that should inform your choices if you decide you want to study one or the other. Okay? These are mostly OAI inclusion criteria, so let me walk them through with you. Men and women age 45 to 79, that's true in OAI, and most the people are slightly older, 50 to 79. Both studies oversampled African Americans. Both studies included a sub-cohort with symptomatic NEOA and a larger group that did not yet have symptomatic NEOA. Exclusion criteria were those with rheumatoid arthritis or other inflammatory arthritides. In OAI, they studied only people who could get MRIs, who were eligible for MRIs. In most, we did not. We have a subsample that doesn't ever have MRIs because they were ineligible. We wanted to be more generalizable as a sample than was OAI. And bilateral end-stage NEOA was excluded from both studies. So here's the definition of symptomatic tibiofemoral OA. You'll notice a lot of similarities because the same people designed both studies, and these were our views of how to define these entities then, okay? And they haven't changed drastically since then. So symptomatic tibiofemoral OA in OAI is defined as the combination in 1 or 2 knees of both a radiograph that's positive for OA and frequent knee pain, defined as a positive response to the question, have you had pain, aching, or stiffness on most days of a month in your knee in the past year? Okay? And the most question is worded just a little bit differently. It's in the past 30 days. Okay? But it's roughly the same question. And control in OAI, there's a very intriguing and valuable group that when it was designed, I was vehemently against. And now that it's been collected, I love it. I think it's really good. Okay, it was a really good idea. As an epidemiologist, I was taught that controls are the word control came from the French of witness to the baseline population. And to me, these, quote, controls were not controls at all. They were super healthy people. And so as an epidemiologist, to me, that was just anathema. I couldn't deal with it. But it turns out that they're quite valuable now in genetics and other studies. As we've tried to separate people with disease from people with really no disease, the distinction between 2 very different groups has become quite valuable. And I think that's probably true here, too. So the controls in OAI had no symptoms or radiographic OA and no risk factors. These are basically older men and women who are completely healthy, okay? And they have no knee symptoms, no radiographic positivity, no nothing, okay? And that's sort of neat here. We don't have that in most. So the most data collection looks like this. There was a baseline 15-month, 30-month, and then 60 and 84-month visit. Those are what's completed. What's in red is what's publicly available, although, as I'll show you in a minute, more and more is coming out. So that's sort of an underestimate of what's publicly available. This is OAI, and what's publicly available is now through 48 months. OAI has yearly exams as opposed to most, which is every 30 months, more or less. And there's a phase 2 that's going on that's now just about ended at 96 months. And there's a lot of data that's coming out as we speak. And these are the 4,800 subjects in most. The data are very similar to data from most. They're mostly, more than half are women. Mean age is in the early 60s. This is at the baseline exam. There's a large percent that are non-white. Frequent knee pain is present by definition in those with symptomatic knee pain, symptomatic knee OA. And it's present in about 30% of those who don't have symptomatic knee OA. Why is that? Because they have frequent knee pain, but their x-rays show nothing, okay? And so they don't meet criteria for symptomatic knee OA. They just have knee pain. BMI in the obese range is unfortunately extremely common in both groups. So this is what OAI imaging looks like. They get bilateral x-rays that are PA fixed flexion views that look exactly like this. They get a bilateral knee MRI with a 3T, very fancy Siemens Trio machine, beautiful images. Other joint imaging has been included. So in OAI, you can do a study of hip disease and of hand disease because there's x-rays and symptom information on all of that, okay? In most, we don't have x-rays of the hands or hips, although we're working on hips. We have symptom information on the other joints. Full limb for knee alignment was done at various exams in an incomplete sample. MRIs were obtained of the thigh for muscle and muscle fat, and you can see there's a lot of data release information. I'll give you a little bit of data on retention. These are professional clinical centers. They do clinical center work for their living. They don't do osteoarthritis, these places, okay, most of them, okay? What they specialize is recruitment, retention, and examination of subjects, and they're awfully good at it, okay? So they retain 90+% or 85+% of patients, subjects followed over time. This is not like a clinical study where the clinicians get involved and maybe, figure out how to recruit somebody back. Okay, these are people who do this for a living. So data now available, you have to register for the most study online, sign a data use agreement and download it. Register at OAI online, sign a data use agreement and download it. Those are the websites. I understand you have these slides in whatever was given you, so you can get you can also Google most in OAI and get it easily. These are downloadable public release data sets. There's an outcomes database, image data sets on request, imaging inventory and study planning databases, and there are, for both studies, central image assessments and radiologic outcomes, and they're widely available. So just to give you a sense of the differences between, you might say, well, which should I use? So as I said to you, OAI is a bigger data set. It was funded by contract. That contract requires that the data isn't owned by anybody. It gets released, okay, after it's been collected, okay, it's not grant funded. It's contract funded by NIH, okay? So that means when the 96-month visit is done, it's going to take them a while to clean the data, okay, and make sure the data is pristine and easy to understand. And then maybe a year after the 96-month data is complete, it'll be released to the public, and you'll have an opportunity to get at it. Up until now, you just saw that it's released to 48 months, but that's not going to be true for very long, okay? And you'll have the opportunity to look at really long-term outcomes in people with knee OA and at risk of knee OA, okay, with a very well characterized, high-quality set of data. So every 12 months through 96 months, age 45 to 79 at baseline, the risk factors of eligibility include some that, in my view, really are not risk factors for high risk of OA. And that's why you'll notice in a minute that the OAI group doesn't have as high a rate of disease or as high a rate of severe disease as the most group, because a lot of risk factors were included that frankly aren't risk factors, okay, or not very good risk factors. And that includes relatives with TKR, any relatives with TKR. If either of your parents had a TKR, you're at risk, especially if your mom did, but not if a cousin had a TKR or an aunt and uncle. Frequent knee bending as an occupation that you no longer do, if you don't have OA now, is not a risk factor for subsequent OA. Hand OA is. So there's a variety of things in here that make it so that this is not as high a risk group as this group. Okay, so the most group is overweight or with a knee injury operation or had knee pain without radiographic OA, and they have a lot of disease. Okay. So WOMAC symptoms and function were assessed the same way. Performance measures assessed similarly. Physical activity measures assessed similarly. The x-rays in most are a little bit richer than the x-rays in OAI. There's lateral weight-bearing films, which are very informative, that weren't acquired in OAI. And the MRIs, you can't see down here, are far better in OAI. The disadvantage is that they're not read, okay? So that and the reading is very selective and limited, whereas the most MRIs the reading's been released at a fairly early stage in the study. So which should you prefer if you're doing a study? Well, generally, I think you should prefer OAI, okay, especially for rehab, large-scale rehab stuff, okay? It's more sophisticated. The MRIs are far more informative, although the major problem with OAI is that the MRIs are read by grant and not by contract. That means that what started as a public study, for a large percentage of the most interesting questions, has turned into a private study, okay, which is terribly unfortunate, but true. It has larger numbers of subjects. So if you want MRI data, you may need to go to most, or you may need to write a grant to get the OAI MRIs read. OAI has a larger number of subjects. Follow-up is more frequent and longer, and there's more data released. So for a lot of reasons, OAI is the preferred data set. Most has more, if you're interested in knee replacements and knee replacement outcomes or risk factors in knee replacements, most is a cohort that's got more severe disease, okay? And there's a lot more knee replacements there. If you're interested in studying disease functional outcomes, it's worse in most, okay? You'll get different information. There's more biomechanics risk factors collected, so most is a grant, okay? It's not a contract. So what that means is that we, the holders of the grant, are under obligation by the NIA, the funding agency, to release most data, but not until we've answered the questions in our grant, okay? So we do release most data, but it's a little delayed compared to OAI, okay? So what's been collected recently is a variety of interesting biomechanical and functional risk factors, but you won't see them for a little while, okay? But you will see them sooner or later. Spatial temporal parameters of gait, co-contraction data, EMG data, okay? A lot of it's been collected as part of most. It's slightly richer in terms of psychosocial or environmental data. Julie can speak to that. A large percentage of MRIs are read with data available. So if you're interested in MRIs from baseline to 30 months especially, the data's all released. The cohort is more diseased than OAI. Okay. So these are most data release stuff. You can see 0 to 30-month stuff is all released, 60-month telephone interview and clinic visit is released, and the release is scheduled soon for even later follow-ups. And OAI data set releases now are up to 84 months, so you can really get very long-term perspective, or much longer-term perspective than we've previously had on osteoarthritis and risk factors for disease. So let me give you some examples of recent papers to give you a sense of what might be done with these data sets. So leg length discrepancy from the long limb films, okay? Showed that leg length discrepancy increased the risk of osteoarthritis. This is work published in a very prominent general medical journal, showing that short limbs, if you have a leg length discrepancy, short limbs increase your risk of getting disease and of getting progressive disease, something that may well be a treatable finding, okay? Medial patellofemoral disease is as frequent as lateral disease in the patellofemoral joint, a finding that violates all we know about patellofemoral disease, okay, including what is often called the law of valgus. And we wrote the paper called Breaking the Law of Valgus, okay, because our findings show very convincingly that medial disease is every bit as common as lateral disease. A paper from Dan White in the BU group who showed that worsening radiographic OA correlates strongly with worsening physical function. I think not a huge surprise, but nonetheless an important finding. A finding from OAI and the Northwestern group that's working with accelerometry data in OAI, showing physical activity guidelines are not being met by persons with or at high risk of osteoarthritis. By the way, the accelerometry data in the last 2 or 3 months was released for OAI, and so it's publicly available data. You can get your hands on that data and ask good questions about physical activity and its relation to disease outcomes. Weight loss leads to improved physical function, a terrific example of someone outside of these studies, not part of most in OAI, not an internal investigator, okay, who noticed that there was a whole lot of weight loss present in both most and OAI cohorts, and wouldn't it be nice if we could look at what effect that weight loss had on physical function and physical function trajectories later? and found impressive effects of weight loss on stability and improvement in physical function in a very valuable paper that shows that it's a wonderful example of how you can take advantage of these publicly released data sets. You don't even need to talk to me or Mike Nevitt or anybody else, okay? They're very well characterized and documented. You could download them and do a bunch of your own analyses that will be insightful for you. So you can work or publish independently. You can also participate in most and OAI publications processes if you want. It's a little bit easier to deal with most if you come to most investigators, in part because it's a grant and because there are data that may be of interest to you that aren't yet released that you can get access to if you work with the most group. With OAI, that's not necessarily the case because the data really are publicly released just as they're done, okay? And they're very well documented and characterized and quite clear to people. So I think you have a choice, though, of if you want to use either of these data sets, of participating in the most OAI publications process, collaborating with an investigator in most and OAI. You can complete an analysis form to register your topic and email to most and OAI online. If you do that, then at least with most, you can be assured, this is a little bit like a dog demarcating their territory. You know, in the most study, if you do that, what happens is you can be sure that no one else will take your topic and run with it, okay, which is a nice situation. In OAI, you don't have that assurance because it's a publicly released data set. Anybody can do whatever they want with it. If you want to work with OAI investigators, that's quite reasonable, and you can sometimes get good advice on how to do that. Optional is to submit an analysis proposal for feedback. You'll often get constructive feedback, and it avoids unintended duplication of effort and fosters collaboration. I recommend it. I think there have been a bunch of external people who have come, and they learn a little bit more about the data set and what variables are strong and what variables aren't strong, okay, and how to deal with some of that stuff. And then you can submit a manuscript for review, especially in OAI, and obtain the Good Housekeeping seal of approval. They'll put it through a review process before you ever submit it to a journal, and that's often very helpful to you. The OAA process, you can do this at any time, at any junction. You can submit an analysis plan, involve the other investigators in OAI, or you can just submit a manuscript. You can do it at any point. In most, if you want to use some of the data, it's better to start with an analysis plan and go from soup to nuts, because then you'll involve most investigators. And, you know, and they're very different, most investigators with different expertise. Usually if you want to do a biomechanics-oriented most study, we would hook you in with the people in most who do those investigations, and they'd probably work with you. So future developments include continued public release of data and images from most in OAI, dates yet to be determined. Imaging and biochemical biomarkers from sponsored ancillary studies will gradually get released. I think the frustration with OAI, if there's any frustration, is that there are people who are reading MRIs in large quantity and that you and I don't have access to them necessarily. There's continued innovative and informative uses of the data by the OA research community to help meet the challenges of osteoarthritis, and of which, as I said at the beginning, there are very many challenges. And I think these data sets are a great opportunity for anyone early in their career to think about questions that you might address, to take advantage of some of these data, and then to pursue your own studies which measure things more intensively and in a more granular fashion to get at some of the questions we need to address. Okay, why don't I stop there? Thanks.